My case is a 45-year gentleman from Kanyakumari who is farmer by occupation presented with a non-healing wound over back of right knee for past 9 months. It started as a small wound which was gradual in onset and progressed to attain the present size. He has history of flame burns injury at the age of 13 years which was treated with dressing. History of pain over the wound for past 1 month. No history of any other swelling. No history of discharge or bleeding from the wound. He is a diabetic for past 5 months and on medication. General examination. After taking consent, I examined the patient in well-lit room. The patient was lying towards the left side with the right leg slightly flexed. Burn scar is seen in the right popliteal region. No other scar or sinuses seen. The patient is conscious, cooperative and oriented, moderately built and nourished. Karnofsky score 90%. Not anemic, not jaundice, no clubbing, cyanosis, no pedal edema, no lymphadenopathy. His vitals are normal. Regional examination. Patient was examined in well-lit room with adequate exposure from umbilicus to toe. Inspection. He has a single ulcer in burn scar of size approximately 4 into 2 cm noted over popliteal aspect of right lower limb. It laterally extends till 3 cm posteromedial to the head of fibula.
Before we go to the examination history part, you have only a 9 months telltale history of the eventful ulcer formation, isn't it?
Yes.
Before 9 months, since the age of 13 onwards, he sustained a burn from that.
Yes.
That scar remained innocuous.
Yes.
That is to be clearly seen.
Yes.
There was no itching, no peeping or intermittent giving way or anything like that.
He did not notice.
It was not a chronic irritated scar at all.
No.
It was a de novo development of the site of an innocuous well-healed scar for years remaining, and later the malady started 9 months back.
Yes.
That's what you mean to say.
Yes.
There was no provocative cause like constant itching or
no trauma.
Something like, or applying any medicaments etc. to the site.
No, sir.
Not subjected to any further surgery at all to the scar also.
No, sir.
Some days you may get the escharotomy, those things etc. And that was not. There is no history.
No.
Okay. Now we can skip that because of time limit, but come to the local examination.
He has a single ulcer in burn scar of size approximately 4 into 2 cm noted over popliteal aspect of right lower limb. It laterally extends till 3 cm posteromedial to the head of fibula. Medially extends 3 cm posterolateral to the medial condyle of tibia. Superiorly 3 cm above the level of knee joint. Inferiorly 1 cm below the level of knee joint. It is irregular in shape, well defined and irregular margin, raised and everted edges. Floor is filled with slough. The ulcer is surrounded by hyperpigmented patches and the burn scar extends till 6 cm above the level of knee joint and 10 cm below the level of knee joint. Left lower limb is normal. No other swelling is seen, especially inguinal lesion. Palpation. No local rise in temperature, tenderness over the ulcer, single ulcer in the burn scar of size measuring 4 into 2 cm present over the popliteal aspect of right leg with above extensions, irregular shape, well defined and irregular margin, raised and everted edges, floor filled with slough, restricted mobility, base is indurated and formed by burn scar. Surroundings.
I need to stop you there, because an interruption, of course. You said irregular shape.
Yes.
Is it acceptable or not?
Slightly oval.
Shape of the ulcer is not described as regular or, for that matter of undergraduates teaching. I just need to tell one thing. Just to blindly learn, regular and irregular is a characteristic of a swelling surface alone, not about the border. Border is actually always described as ill-defined or well-defined. Border need not be described as irregular or irregular, except for visceral enlargement. Say, for example, some days medicine people teach us that the liver is having a little sharp irregular border. That is taken for granted. But for that, any swelling surface is smooth or irregular. That's all. And border is well-defined or ill-defined. As far as an ulcer is concerned, shape of the ulcer should be better described as fitting to any of the shapes which we know. As for example, oval or or rounded or elliptical and so on and so forth. That's how. Then you do not mention it as shape is irregular. Okay. Then anything else criticizable for others to learn? He has very well depicted it in a narrative way. Single ulcer, scar tissue measure, scar tissue extent you mentioned, and you painfully attributed it to the malleolus, etc. from there. That much may not be asked for an UG student. Anyway, it's good enough or excellent as to say as a comment.
And you did that floor filled with the slough. I think that comes under inspection, not that healthy or unhealthy granulation slough. That is inspection point. Floor filled with the slough, I don't know how you put into that. And one more thing I want to, sir, with your permission, I want to tell you one more thing now. When you present a case, so your teachers may not know everything, and we don't expect the student also to know everything. Okay. So when you present the case, you must present very confidently, as though we don't know anything.
Yeah.
That is the way of getting the impression of the teacher.
It's actually mom's wisdom, because feel confident yourself.
Yes.
Then you feel comfortable with others, you have to be comfortable. So feel confident with even teachers, but don't overdo. That's all.
Don't overdo that. Whatever the teacher, even if he says wrong, you must say, yes, madam, yes, sir, yes, sir. Don't argue in the exam. And the second thing is, this is short case now, sir. In short case, never read from the people. You must be able to present without seeing what you have written. I don't know, but other MGR University, we don't allow you to go read that exam method. So only if you start preparing, presenting now, you will be able to do it there. Here, sir?
Yeah, I fully agree with ma'am's statement, because the confusion is usually short case whether to write and present. No. Yes. It's only for the long case as far as Kerala University is concerned. I think the same is holding true everywhere. And the confusion was created because I don't want to gossip my other specialities, but ortho people have taken part of the marks of our original general surgery paper, and they have only one short case to be present. So they have insisted probably to write it down, but for our sake it is not. Short cases are always short, not long case at all. Long case, it is mandatory for us to be the examiner to look into the nature of writing. Even something wrong, we will put circles or ovals, etc.
Remarks. And you should only in the short case relevant history and a clinical presentation. That's all in the short case. First thing, you should not look from the paper. Even long case, you have written. If you write in the exam on your own by properly examining, you will not read from the paper. So from that, the examiner will know. They will never do that. So practice writing long cases, practice. Short case, you must write the relevant history, because 150 students, 20 students in a batch, the examiner will not get the patience to listen to you all this history. So only the relevant history and the physical findings. So when you bilateral structure, always mention which side you are telling. That is also very, very important. Just as said that irregular shape is not correct. Okay. So these are only my suggestion.
To add to that, one more thing, there was a clear confusion between the slough and floor and those things. How do you just simply, in simple English, say what is the base of an ulcer and the floor of an ulcer? I had a great teacher by name Professor Manmohan sir, in whose unit I was there in third year posting and also final year posting. So sir used to teach us very simply this thing. I just want to propagate that message to all this crowd of students. If you know that, please tell me. Then it is easy. What is the difference between base of an ulcer, floor of an ulcer? With examples.
Sir, what we see by external appearance of the ulcer is a floor, sir, and what we feel inside the floor by palpation is base.
You are partly right, almost right, but there is some more simplification easy. My teacher used to compare it with a table upon which a bowl is placed. And what I see, look into the bottom of the bowl is the floor. What I see as filling that bowl inside, water or milk or whatever it is in normal case. In a case of an ulcer, slough or granulation tissue, what is the nature of the slough? That are all described by the floor of the ulcer. Whereas, the table upon which this bowl is placed, that is the base. You not say that it is the depth of the floors or this is the base. No. It is the surface upon which the ulcer rests. That is the base of it. Maybe muscle, maybe fascia, maybe bone, or maybe bone deep even to the depth of the bone, etc. So, typicizing the example, this is, I think this is what is learning, so we have to explain as teachers. Typicizing that a floor is said as having granulation tissue. What is granulation tissue?
Repair.
For everything there is an easy description. That's why I am asking question. Granulation tissues are better described as sprouting dash. What is it? Anybody? Capillaries. That's a good answer. Sprouting dash. Just like our chambarati poo in Malayalam is very red, bleeding to touch, irritating. It will bleed profusely because it is sieve-like opening rich. The branches from the arteriole. So, if an ulcer is healing, then it is filled with the healing element. The source of factory of healing element is the capillary. That's why it is. Now, the base is filled with slough in case of an unhealthy ulcer or an advancing ulcer. The slough may be described even to throttle with information or to create a shake. You may have apple jelly appearance, you may have the wash leather appearance, etc. for specific ulcers, but that is very rare nowadays. But non-specific ulcers, whatever it is filled with slough or pus. That is it. So that thing, I hope that is very well clarified. The table is the base, and as you rightly said, very excellent answer. Sir, base is better made out not by inspection but by palpation. When you see a hardening feel of the tissue upon which the ulcer rests, of the surrounding tissue, that is the base. Then you name it as a typical technical term, indurated. This induration is not a feature of malignancy at all. It may be a feature, it is there for malignancy, but it can also be a chronic inflammatory ulcer also having this. I think that is well clarified.
Thank you, sir. Summary. 45-year gentleman came presented with the complaint of non-healing wound over the right popliteal fossa. On history, he has a burn, he has a flame injury at 13 years of age. No history of trauma.
Non-healing wound or non-healing ulcer, you want to put it in terms?
Non-healing wounds.
What is the difference between a wound and an ulcer? You only probed that question, that's why I am asking. Ulcer is what? How do you define an ulcer?
Discontinuity in
it's a discontinuity of, in our previous editions they were saying with tissue necrosis of the edges. So not like a fresh wound. So that is delineated as fresh one. But now there is the recent definition of ulcers is a discontinuity of the covering epithelium. Maybe mucosa, maybe the surface epithelium is it. With added tissue necrosis in case of a typical ulcer. Whereas in a fresh made wound, it is a wound. It may not be named as an ulcer. But a wound can be better named as an ulcer in the long run. Within a week or so, it may become an ulcer. That's all. So here it is
wounds.
Wound or ulcer?
After examination, I am diagnosing it as ulcers.
Ulcer. So then you say the summary, you can say it as an ulcer better than a wound.
Patient will say the complaint as wound. Syria, if you translate from Tamil or Malayalam, you have to appear your exam in English. So you have to mention as wound. In a chronological order, if you write this, patient complains of wound. But after history of present illness, when you write, you must write in technical terms as ulcer.
Yes,
In his term, wound is correct. But as a doctor, when you present summary, you must present it as ulcer only, not wound. Then what is the difference between him and us?
Yeah. That is a summary. You can tell it in your observation findings also. But history in patient's own language.
Yes.
Right. I think well clarified.
Thank you.
Yes.
On examination, the single ulcer over the burnt scar on the right popliteal fossa, it is vertically oval and irregular margin, well-defined margin with irregular and the base is indurated.
No, my boy. Because the very important thing, just finger pointing to us as a arrow mark is the edge. You have to comment about the edge. Then only we can substantiate a diagnosis. What is the edge in the picture? In the picture of this ulcer, project that pulsar. Is it typically to describe into a malignant ulcer, the edge in this case? Yeah.
Some part is slopy.
No, look at this one. Yeah. Some part is sloping, mainly sloping. It's the meaning I am asking that question. In a case of a scar ulcer, it's an ulcer, squamous cell, I agree, originating with a funny name of marginal cell later, but the ulcer may not be typicized like squamous cell carcinoma elsewhere. That's why you are in a dilemma whether to, in front of teachers, should I put it as everted, should I put it as slope? I agree fully, this is a sloping edge as if it is a healing ulcer. Unless it erodes to the normal tissue, then you get an everted edge. That is why you find it difficult. So what is the edge looking like? Mainly sloping. Is it mainly sloping? Sloping is a feature of
Healing ulcer.
Healing ulcers. So it heals on that side, but it is not exuberant in granulation. Sorry, exuberant in its multiplication as in case of a squamous cell carcinoma at the edge. Two words I need to stress for them. There is an R, rolled out, and a roll. My professor was very particular to teach us this because 3 R's for rodent ulcer. That is raised, rolled, rodent. But it's not rolled out. Rolled out is a feature of squamous cell carcinoma. So that students, please make it upon your heart, Gaira and Salse. Rolled simply implies just beaded appearance. Raised as it is, vertically raised. Whereas rolled out, because of the speed with which it goes, it falls on one side. So it is like cauliflower, and that is squamous cell carcinoma.
Thank you.
Okay.
Provisional diagnosis: Marjolin ulcer secondary to burn scar.
Marginal ulcer secondary to burn scar. Okay. Marginal ulcer, what do you mean? It is a type of, as far as ma'am was today morning, talking with excellent words and slides about the skin malignancy. To which type you will fit marginal ulcer? Squamous cell, basal cell, melanocytes.
Most commonly squamous cell carcinoma.
Squamous cell carcinoma. It is not most commonly. It is a squamous cell. It's a variant of squamous cell carcinoma. By the slide itself is very explanatory because it is sloping, because this squamous cell arises from the squamous cells of the scars, not from the usual replication rate, and that is why it is not typicized as a squamous cell cauliflower shaped ulcer. Will it spread to the lymphatics?
When it's overgrows the scar tissue.
So, because time is limited, we need to delineate the difference between a marginal ulcer and an usual squamous cell carcinoma. That's why I am asking. Will it spread to the lymphatics?
When it overgrows the scar tissue, it can go.
Very good, excellent answer. Give me a big sign for yourself. Only when it exceeds the normal limit of scar and the normal tissue, invading the normal tissue, then it becomes cauliflower. That's it. So, will you look for lymphatic nodes in a case of that? You have to still, because we don't know which area there is a continuity between the border and the scar. So, we have to examine the lymphatics. Regionally, what is the status of the regional lymph nodes here?
No.
Where will you examine for the regional lymph nodes of the popliteal fossa usually?
Inguinal region.
You have to check for inguinal also. The popliteal we cannot palpate at that floor, it's at a level. So, we have to look into the lymphatics of the groin. That is it. Okay, come to the investigation. Ma'am, anything else? No. Come to the investigations.
For diagnosis, I would like to do wedge biopsy from the edge of the ulcer and send it to histopathology and culture. And
histopathology, culture?
Histopathology.
Histopathology. What? There are two ways of histopathology. I am not asking about cytology. Hope that you all know the difference between cytology and histopathology. Cytology means study of individual cells shed there. You may get multiple cells in an aspirate, but in study of the individual cells. There is no core. The core biopsy or tissue biopsy means a complex city of multiple cells there. And then only we can have capillary spaces there, capsular spaces, etc. to be seen in case of particular tumors. So the biopsy implies a study of a core of cells or a core of cells. Actually normally aligned as in case of in situ in the body. Then only it is a biopsy. So here the biopsy is of two types. One is an immediate biopsy, then and there the surgeon waiting. What is that? It is named as a frozen section study. And second is you wait for the report after technically, surgically, scientifically assessing the clearance margin blindly and sending for biopsy. That is a histopathology. Over.
Yeah.
Got my point is clear? I think it's in sir.
Ma'am, I have confirmedly rule out the.
Clinically, you said no significant. You must say that is significant or not significant. So clinically itself, it's not palpable. Why do you want to do an ultrasound of the right inguinal region? You mentioned. That's what I'm asking.
Oh, you wrote it as ultrasound of the right inguinal,
Ah,
soft
that
tissue
is the
ultrasound.
reason.
You mean soft tissue ultrasound? What do you mean out of that ultrasound of the right inguinal region?
Inguinal region.
That implies by writing so, that simply implies ultrasound of the soft tissue of the inguinal. Otherwise, you should have written ultrasound of abdomen and pelvis. Maybe you will look for deeper inguinal or pelvic lymph nodes, etc. Iliac lymph nodes, etc. But you have written right inguinal. So you want to locally know whether there is, you want to confirm the lymph nodes are enlarged or not, then you have to confirm whether it is significant or not.
Yes.
That's our question. I think we have today morning we have discussed significant and non-specific. Yes. So I think that was answered well. We are not repeating, but ma'am was asking about that, whether significant or not, and then what is the purpose of inguinal soft tissue ultrasound there. Can you answer? Is there any?
Ma'am, from oval to round changes can be seen.
If you don't know the answer, no, you should not answer to the examiner. You can keep quiet. It's better. I'm telling you this because no, deviate from the original case you are presenting. So never answer. If you say sorry, sir, I don't know, that's okay. But you should not have written as right inguinal region.
Yeah,
that is my cause.
You need not write. You should not have written like that. You can say ultrasound. Maybe you will face
pelvis,
if at all question only. That's the reason. Can you pick up iliac nodes, subclinical, etc. under ultrasound? Clinically nothing palpable. Then what is the purpose of doing an ultrasound? The answer should be, sir, you want to just have a survey of the iliac, the common iliac, para-aortic, etc. if they are involved. They are not accessible by the hand. Then only ultrasound is justified. And you can have the visceral survey of the entire liver, spleen, etc. My professor used to again give, he's fond of teaching simple things. That's why I am just follow, I will not reach anywhere near his level. But I believe we have to try for betterment. So there, sir used to say a short form PALS. Primary, any other, lymph node and spleen. Whenever you get a lymphatic. So you have to have a hepatosplenomegaly. Any other primary, I could hear the primary is understood, that is not. Then liver and spleen. Any other means any other lymph node of the neighborhood as secondary station or skip lesions. That is the reason. How will you manage?
Sir, wide local excision with 1 centimeter margin and
you should make a decision of the therapies. And here, do you opt for a prophylactic inguinal node dissection in this case, or you will just treat only the ulcer? I may be asking foolish questions, but yeah, just to get whether what is your concept. That's all.
Sir, I will just.
You didn't get any lymph nodes palpable at all. You are clinically not confident whether it has invaded the border or not. But seemingly it appears that it is not encroaching the border. So what's your treatment?
Sir, I will treat the ulcer and I will follow up the patient.
Ulcer, how will you treat? What clearance? How much clearance?
1 centimeter clearance.
Good answer. It's an excellent. 1 centimeter clearance is enough for squamous cell carcinoma. So that much wide only is not like others, like malignant melanoma having 4 to 5 some days in some day extensions. That is a single thing. I think this morning she has taught you about squamous, basal, etc. in listed and the management in short. Probably I was taking a break for the washroom, so I didn't listen totally, but probably she might have mentioned this.
Precaution you have to take when you plan for wide excision in this public
Distal pulses.
distal pulses. So when you go for wide excision, you have to be careful about the popliteal artery.
Yes.
You may not know the level of the popliteal artery. It's a scar tissue. So
Yes.
it must be very careful in delineating the popliteal artery as well as the nerve.
Yes.
Any examination is not complete without examination of the joint, and you didn't mention anything about the movement of the joint, so that it is, you can always say restricted by pain, something like that. And as madam said, that is vascularly important. Instead of in ultrasound addition, I would have suggested a Doppler also, because post-operative complication in your days it is evidence based and court litigation are all very common. So before surgery, whether the vascularity everything is normal, is better to have Doppler also, which I feel is
Yeah, but she only rightly highlighted because there is a contracture possibility of the burn scar. So probably the joint might have been hemi-frozen or at least partly frozen. The range of movement should be mentioned, whether it is flexed or flexion is complete, extension is possible fully, etc. That has to be mentioned along with the findings, and examination of the joint knee at least is mandatory. So call it a day. I think if any queries the students want to raise towards your classmate, not to us. Good competitive spirit is not to hurt the colleague or hurt the classmates, but still it can be competitive academically, isn't it? Shall we call it a day for this case or anything else?
prestigious for the exam.
Okay, thank you.
And don't write anything in the your answer paper which you don't know. So if they ask you that, you must be able to answer. And one more suggestion: when you write an investigation, for example, if you write an ultrasound, X-ray, you mean what part you are going to say, what view you would like to take, and what in result you will get out of that relevant to that case. So like sir said, no, inguinal node ultrasound, why you take that ultrasound abdomen, that iliac nodes, like that. Whenever you write an investigation, you must be able to justify why you are asking for that investigation. That is, you have done very nicely. All the best for your exam.
Thank you.
I think it's a big thumbs up for him also. He has done reasonable justice to the responsibility assigned upon him, isn't it? Good luck, best wishes.
Thank you, sir.